So today I'm very happy to attend the lecture of Sridhar sir because we have all seen their videos, and they are short and crispy videos which are very helpful to us. So we'll right away go to it. But before that, I would request Shwetal ma'am to say a few words.
Thank you, Dr. Kunal. Yes, rightly said. It is like dream come true to have a guest speaker as Sridhar sir, because we all his videos and his online sessions are so popular among our peer colleagues and peers. So welcome you, sir. Pleasure to have you on this platform of NNF Gujarat Neonatal Paatshala academic session.
Uh,
Monish bhai,
Yeah,
you can
thank you.
introduce.
Yeah, thank you, madam. Yeah, it's a short introduction of the sir. Sir is our Dr. Sridhar Kalyan Sundaram. He, he is a consultant neonatologist at the Mediclinic at Al Johar Hospital at UAE. Sir has completed his basic medicine training from the India in 1995 as a best outgoing student from the Stanley Medical College, Chennai. He qualified his pediatric from JIPMER, Pondicherry, and neonatology from PGI Chandigarh. In India, he's completed his MRCPH UK and obtained entry into the General Medicine Council specialist at the registered in the UK in 2005. He obtained his fellowship of the Royal College of Pediatric and Childhood in UK in 2006. He works as a specialist registrar in neonatology at NHS Trust Hospital, Cambridge, UK from 2004 to 2005. From 2005 to till 2012, Sir Sir worked as a consultant neonatologist in Level 3 neonatal unit at which was Vishwe General Hospital near Glasgow, UK. Following which he moved to American Hospital at Dubai. He worked there as a consultant neonatologist and head of the department till 2017. Currently, he is working as a consultant neonatologist at Al Johar Hospital at Ali and UAE. He is examiner of MRCPH clinical examination since 2010 and is a NRP instructor, as well as his special interests include neurodevelopment, respiratory supports in neonates and neonatal skincare, and has a many peer-reviewed publications. He has organized and chaired a scientific committee of many international conferences. He has his YouTube channel for education with close of to 3,000, 30,000 subscribes and over the 4 million views. Okay. Sir, stage is yours for our today's topic. Thank you, sir.
Thank you so much. I really appreciate all of you and the kind introduction from Dr. Monish. Thank you, Dr. Shwetal and Dr. Kunal. And I've seen all your names, and it's very nice to see because we see the NNF Paatshala from Gujarat is doing a great job with regular sessions, and I've seen some of your YouTube shared videos as well. It needs a lot of dedication and commitment to do this on a regular basis because this is in addition to your regular work schedule as well. So really appreciate what you're doing. And again, very kind of you to introduce me in such a detailed fashion. Today I will be discussing enteral nutrition. I'll share my screen. I hope you can see it. Can you see the screen?
yes,
Yes,
sir,
sir.
it's visible.
Yes.
Sir, we need to do full screen, sir.
Yeah, sure. Okay.
Yes, sir.
So, good. So I'll start discussing. So the enteral nutrition, obviously, we will be focusing on the NICU, not on the term babies at home. So, quick overview of fluid requirements in babies, which is going to be the basis for how we decide the feeds and what to feed and so on. And then a rational approach to managing feeds and residuals in the small babies. So we will have some time for discussion at the end as well, hopefully. So why do we need fluids and why do we need nourishment and nutrition? So obviously we have our body's metabolism and homeostasis. There is a certain amount of fluid balance that you need to maintain the excretory function and the hemodynamic balance. Like if you're having less fluids, you'll get dehydrated and hemodynamically you'll be compromised. And we also need a certain amount of fluids to serve as a vehicle. In newborns, especially, we give feeds as liquid, and that is a vehicle to bring you the nutrition. And then adequate intake of calories protein, all these are important to maintain the body balance and to prevent catabolism. In terms of a sick newborn, preventing catabolism becomes a very important factor. Even 1 or 2 days without adequate protein intake will start eating into your body resources. And once the catabolic process starts, it becomes a negative. A baby who is poorly nourished is at higher risk of infections. They also have less ability to heal and repair their body as well. So we will come to that when we discuss when to start feeding nutrition and TPN. So what options do we have? So first of all, we have to decide whether a baby is suitable to feed orally and whether we need IV fluids or TPN if the baby is unwell. So when we come to feeding the baby, obviously the first choice is going to be breastfeeding, and nothing will be better than the breast milk. Even for the premature baby, that's going to be the golden nectar for the baby to help recover and so on. So where possible, it should be exclusive breastfeeding. Even if you're not able to breastfeed directly, you will be using express milk. Uh, Donor milk is available more and more places. Recently, Dr. Kanya posted in the PGA group that we have a donor bank working well. I saw other units in Bangalore have started, and I'm not sure if you have it in Gujarat in the medical college setup, but we will discuss that in the end as well. So donor milk becomes a very valuable resource in the tiny babies, and formula milk becomes the last option. And as far as possible, try to get as much of breast milk into the picture, even if you need to use some formula. In terms of IV fluid, we usually use different combinations of dextrose. Usually 10% is the starting point unless it's an extreme premature baby with hyperglycemia. And the electrolytes will be added accordingly. So usually it's sodium, potassium, and calcium that we need. Or you may use a combination like isolate when it comes to the maintenance fluid. In the extreme premature babies or in the babies below very low birth weight babies, even total parenteral nutrition becomes important because as we discussed about catabolism, if the baby is not getting milk, they need to get total parenteral nutrition because you need the protein, you need the lipids. There is a discussion on whether protein alone can be given to these babies. The answer is going to be no, because if you give protein alone, it will be used as you are using dextrose for calorie needs. It will not be serving the purpose of body repair or enzyme regeneration and so on, which is the main function of the protein, the growth and so on. So you need the lipids as a calorie source in order to preserve the protein for the function they are actually meant to be. Giving the protein alone is like giving a little more concentration of dextrose. That's all. So how do we decide which type of fluid to give? So we have babies over 32 weeks gestation and no clinical concerns. Obviously, even in the developed world, we consider full feeds in these babies. Of course, they may not be able to suck their feed immediately if they are immature. We need the suck-swallow coordination, which starts around this stage. There is another difference in approach in developed and developing countries. In India, for example, you start skin to skin care, kangaroo mother care. The mother is very involved in the care straight away. And so even by 32, 33 weeks, most of you are going for Palada feeds and discharging these babies by 1.5, 1.6 kilos. While here we keep them till 35 weeks. We have regulations from the Department of Health, and these are medico-legal issues. So we don't discharge them before 35 weeks and 1.8 kilos. And of course, we have time in that sense. We don't rush to progress to suck feeds, and Palada feeds is an option, but parents may choose either bottle feeding or Palada when the breastfeeding is being established. So that's going to be a difference. In Indian setup, we avoid the bottle as best as we can. So you give Palada or breastfeed so that when the baby goes home, they can breastfeed directly. It's important to give adequate volume of feeds from the day one because the hypoglycemia is a risk. So if you're not giving IV fluid, you still need to give a good volume of milk like 60 or 80 ml per kilo, because if you give less, they may become hypoglycemic. You still need to monitor the glucose and give the correction as needed. It's very important to focus right from the antenatal period on breastfeeding. We don't expect prematurity, so unless you have multiple pregnancy or other concerns, you may not know that a particular baby is going to deliver premature. So even though antenatal expressing is becoming a concept in infant of diabetic mothers, for example, where we know that there is a risk of hypoglycemia postnatally or in multiple pregnancies, other pregnancies, they start expressing only after birth. And we know that lactogenesis has 2 or 3 days to set in, and even if the mother has milk on day one, they may not meet the full needs like 60 to 80 ml per kilo. So that becomes the stage where you consider donor milk if possible, or you may need premature formula for that time when we are waiting for the mother's milk. So we have to encourage that with skin to skin care. early feeding, expression within the first hour of birth. So many studies have shown that initiating the breast milk expression early on helps with getting the milk output early. And obviously, if you have a donor milk bank and milk sharing, I mean, pooling of milk within the unit in an informal way is not advisable because we don't know the medical legal implications if there is any viral infection coming from that. And you obviously need to screen for HIV, hepatitis B, and everything from the donor. So some mothers come with a question of my sister giving the milk and so on. So you can consider that, but it has to be with consent and explaining all the factors and consider the blood test for the one who is going to share as well. So this is a very interesting study by Dr. Sushma and team. Obviously, uh, they selected babies about 28 weeks who were stable. So they did not take babies on respiratory support or any other sickness. So these are relatively stable babies, and majority of them, the mean age was 31 weeks and the mean weight was 1.3 kilos. So obviously, the smaller the baby, even though they included 28 weeks and above, not many 28 weekers would fulfill the criteria of not needing respiratory support. So typically, you would have this approach as 30 weeks and above. And there was a survey by Engelberg and Embleton in UK. They also said that above 30 weeks, if the baby is hemodynamically stable, more colleagues are comfortable starting full feeds from day one. And obviously, if you have express milk in that amount, it's much better, but EBM or donor milk is better. And early exposure to formula has to be weighed with a pinch of salt. You might have seen the news from US that uh, Mead Johnson was sued because the premature baby developed NEC, and apparently they didn't have the information in the leaflet about the risk of NEC. So they were going to be sued for $60 million, and their judgment was in the favor of the parents. So when it comes to these situations, I know it's multifactorial. I made a recent video on that as well. So it's not easy to segmentalize when we come to express milk or donor milk versus formula. The breast milk based milk product supplements that we have are very expensive and not readily available. Donor milk is also, even if you have a donor milk bank, if you're a big unit, you may conserve it for the babies at highest risk of NEC, which is the extreme low birth weight or extreme premature baby. So you may not still have the donor milk for a 1.2 kilo or 1.5 kilo baby unless it's really a big donor bank. So you still have to conserve because it's a valuable resource. And so EBM at the word go is becoming the key. And if you don't have enough EBM, what do you do? Will be the question as well. So the purpose of feeding is to meet the requirements in terms of calories, proteins, and other supplements. So the fluid requirement is in a premature baby 135 to 200. I don't usually go to 200. We stop with 160 to 180 maximum. And in term babies, it's a similar volume. Energy requirements for a premature baby is higher, 110 to 135 calories, and for term infants 90 to 120. This is per kilo. And protein 4 to 4.5 for the extreme premature baby. For more than 1 kilo baby, 3.5 to 4, and the term baby 1.5 to 2.5. And these are the supplements which we will discuss. If you're adding the human milk fortifier, most of these are covered in that. You may give additional vitamin D and you may give additional iron. But if you're not having fortifier, you will need to add calcium phosphorus as well. And some of these babies may need sodium supplementation because of late onset hyponatremia. So we have a stable admission in the NICU. It's not really a premature baby, but it's a term baby who has come in for TTN or some other problem. But baby can be fed by tube feeds while baby is there. So do we start with donor milk or formula in these babies while we are waiting for breast milk, or do we give IV fluids? So obviously parental involvement is important in these cases, and you would need to go with their opinion as well. So both breast milk, donor milk, and infant formula contain the nutrients needed for the growth and repair. So even a short period on just dextrose can lead to catabolism, and it might set the baby back in the growth process. Feeding keeps the baby more comfortable as well. So we assume that if the baby is kept on dextrose, they will cope, but there may be unrecognized effects of the lack of adequate nutrients in the early stages, which is critical for programming. You wouldn't go for TPN in the routine cases like what I described because it has its risks, it's expensive, it can be injurious to the liver and so on. You need a central access in most of the situations. Peripheral TPN has a high risk of extravasation injury. And of course, there is a risk of infection. So in stable babies who are bigger, you wouldn't really consider TPN. And any intravenous intervention has a higher risk of infection compared to oral route. So if you are tube feeding with express milk or donor milk or formula, it's better than starting IV if the baby will tolerate feeds. But if you are using formula, make it clear that it's a medical intervention. Make sure you have the support system in place to encourage the milk output. This is a critical part. The 1 or 2 days it takes to get adequate EBM, the mother should be supported very well. The breast pump should be provided after the first day. She can hand express every at every opportunity, 2 to 3 hourly on the first day as well. And we should stress the risk of NEC, as I mentioned in the earlier discussion. Always, if you have a consent form, I would suggest that we add this, that premature formula or any formula increases the risk of NEC, so we don't end up in a situation like what Mead Johnson faced. So what are the situations we can give IV fluid? So we may have term or near-term babies with respiratory distress, and you feel the baby is not stable enough to start tube feeds. Majority of the babies in non-invasive ventilation are stable enough to start, but if the baby is acutely unwell and you're considering need for surfactant and so on, or you feel baby might need intubation, you can wait a few hours without starting feeds and keep them on just dextrose. A few hours shouldn't harm. And where there is initial need for resuscitation, you're not sure whether the baby will need cooling or something, you can wait till the neurological course and maybe the CFAM study is clear. Babies with risk factors for hypoglycemia, where you have a low reading despite the initial steps, then you would need to consider IV fluid as well. And babies over 33 weeks with symptoms as above or hypoglycemia, but they're expected to tolerate the feed. So you wouldn't consider TPN in these babies. So you would be going for IV fluid, which is dextrose, plain dextrose in the usual cases. And babies below 1,500 gram and usually below 32 weeks would have a central line UVC or PIC line from the day one, and you would start central TPN. Again, go for full TPN, don't go for partial TPN with just amino acids and dextrose, because we discussed that earlier that you need to conserve the calories. The babies below 33 weeks and birth weight less than 1,750 gram with significant symptoms, we expect the baby to take longer to tolerate the feed. So in these situations, you would again start TPN, but it's not essential. You can wait 2 or 3 days with dextrose with the trophic feeds and gradual progression. And if baby doesn't tolerate, you may go for TPN as well. So a central line is not necessary in these babies where you think you can go over 3-4 days to reach full feeds. And babies with NEC or its complications where we need to keep off feeds for a period of time. There are some term babies, especially related to surgical conditions, gastroschisis, for example, they need a long time to tolerate feeds, malrotation after repair. So these are the situations where you would consider TPN. Obviously, this bigger group of babies, we will be going to the standardized feeding regime as well next. But when a baby comes into the eligibility criteria where you would start full feeds when they are stable, you don't need to go step by step. So if the baby is clinically stable and you have reached, say, 30 or 60 ml, you can go direct to full feeds in a rapid progression. So you don't need to go the 20 or 30 ml per kilo per day if the baby would otherwise qualify for full feeds from day one. The sicker the baby, the slower you would go, obviously. If the baby was hypotensive, if the baby was ventilated, you can go step by step in those cases. But if baby has just mild distress in the beginning and settles and improves quickly, you can be reaching full feed soon. So how much fluid do we give? On day one, we give on the lower side if there is respiratory distress because there is a risk of syndrome of inappropriate idiot secretion. And if the baby is having hypoglycemia or borderline sugars, you may go on the higher side and monitor the sodium. If the sodium starts dropping, obviously you would need to concentrate the dextrose. So SAADH can coexist with hypoglycemia risks, so we have to balance that. In a term baby, we may start with 50 to 60 ml unless there is asphyxia. In a preterm, 32 to 36 weeks, 60 to 80 ml per kilo. And 28 to 32 weeks, 80 to 100 ml per kilo. And babies less than 28 weeks, we can start with 100 ml per kilo, but you would need frequent assessment and increments because there is a risk of hypernatremia. Urine output may drop. Hyperkalemia in these babies is a risk as well. So you need to relax the fluids much more than the other groups, and you need to make frequent adjustments and monitoring in the tiny babies. From day 2 onwards, usually we increase by 10 to 30 ml per kilo per day, and sometimes you may go in 12-hourly steps of 10 ml per kilo if you are not sure whether the baby needs more. So sodium you are monitoring, the weight you are monitoring, and you may not jump to 30 ml per kilo per day increments. You may increase 10 ml review in the evening with the gas sample for sodium, for example, and then make the adjustment. The maximum intake usually is 160 ml per kilo per day, except in some babies who need 180. I've hardly ever gone to 200 ml per kilo because the higher fluid you give, there is a higher risk of PDA, BPD, and even reflux risk increases. So we can manage adequate calories with the premature formula or with the EBM with human milk fortifier. So we rarely need to go beyond 160 to 180. And don't forget the important role of temperature regulation, humidity management when it comes to fluid management. Sometimes we don't start humidity in a 32-weeker, but you see the sodium rising to 150, baby has lost 150 gram in one day. These babies I quickly switch on the humidity, and that allows you the flexibility with the fluid balance you need, because each baby is different. You have to individualize the care according to what you see. You cannot say every 32-weeker has mature skin and has less insensible loss and they don't need humidity. So you have to, same in a similar fashion, you have to just accommodate it as well. Even in a less premature baby or more premature baby, you may wean the humidity faster as well. So there are some important things to monitor the fluid balance. So we have vital signs, tachycardia, blood pressure may indicate that you need more fluids. Acid-base balance, you look for lactate and acidosis, which are not direct indicators. Obviously, you don't want to reach the stage where you have a hypotension and a high lactate. You want to pick up before that. Capillary filling time, peripheral temperature, and perfusion are important. You look at the urine output. Serum electrolytes, we may have hyponatremia or hypernatremia guiding your management, as we discussed earlier. We have the blood glucose levels, and the daily weight change is important as well. Some extreme premature babies, you have the incubators with inbuilt weighing scales. You may do it twice a day, along with the urine output monitoring, sodium balance, and so on to check. And the urine output measurement can be using weighing the nappies in these babies. In a premature baby, usually a 12-hourly output is adequate when the baby is stable, and you could do once daily once they are stable. And in the extreme premature, 6 to 8 hourly in the first days, and then 12-hourly will be the standard. So when do we introduce feeds and when to progress? So there are multiple studies which have looked at feeding regimens, and where a unit follows a standard feeding regimen, it doesn't matter if it's slightly different from other protocols. If everyone in your unit follows the same pattern, there is less risk of NEC, and the outcomes, the time to reach full feeds, the time on central line, and infection rate, everything is much better in these babies. And very important to encourage express breast milk right from birth. If no express milk, we may wait 24 to 48 hours in the extreme premature babies. The more premature the baby, the higher the risk of NEC, and the more you want to avoid exposure to formula. Of course, if you have donor breast milk, you don't need to wait. You can start even in the first 24 hours the trophic feeds. If you have just a drops of colostrum, you can use it for oral care. If it's not enough to feed the baby, you can just apply it in the mouth of the baby. If you're not starting TPN, like in a borderline premature baby who is 33 or 34 weeks and is still small, don't delay starting feeds, especially because if the baby is sick, you would only do a phased progress. If the baby is hemodynamically unstable on vasoactive medication, we would stay on trophic feeds during this phase. But trophic feeds can still be given when the baby is on inotropes or has hypotension, unless baby is really unwell with bleeding in the gut and so on. NEC, of course, you wouldn't feed the babies. Umbilical arterial catheter is not a contraindication to starting or progressing with the feeds, but make sure the line is in the correct position, especially if it is in the low position. It shouldn't be sitting near the mesenteric arteries. You should be sure about that. You can use ultrasound guided approach to check the level as well. If there is severe growth restriction on antenatal Doppler, especially if there is reversed or prolonged absent end-diastolic flow, you have to be cautious, but don't be overcautious. There is no evidence to show that holding the feeds for a 5 to 7 day period in these babies or keeping them just on trophic feeds is going to be helpful. Of course, you can be more cautious and follow the high-risk regime of 15 to 20 ml increment rather than 20 to 30 ml increment, even if the gestational age group would warrant a higher rate of increase. So at least for the first 2-3 days till the baby tolerates, you can go with a slower increment, but don't hold on trophic feeds alone. Just start progressing when the baby is clinically stable. Trophic feeds are the feeds that are used to prime the gut to support the enteral hormone system and the maturation of the mucosa. It also has an impact on the healthy gut flora because the babies are invariably exposed to antibiotics in the early stages, and breast milk as well as cesarean, the normal delivery, improve the gut microbiota. In addition, early feeding, not keeping the baby NPO will help you develop the gut microbiota in a healthy way. Dysbiosis has been shown to have an impact on multiple aspects of a premature baby's outcome, especially the gut health and NEC, but even the neurodevelopment and so on as well. So it's very important to focus on gut health from the word go. When to start increasing feeds will be a clinical decision based on overall stability and evidence of gut motility like bowel opening. In some very premature babies, you may give glycerin suppository or even a rectal wash to stimulate the gut motility. And in the extreme premature babies, sometimes we give gastrographin to allow the inspissated stool to pass if they are not tolerating the feeds. So most units increase 15 to 20 ml per kilo in babies less than 1000 grams, which is a high risk group. And what I mentioned in the severe IUGR babies, when you apply the high risk group, you'd follow the same approach even if the baby is little over 1000 gram or even 1500 gram. In the bigger babies, you would follow 20 to 30 ml per kilo per day once they start progressing from trophic feeds. And when we say progressing from trophic feeds, we actually start looking at increasing from the day 2 itself. You start with trophic feeds on day 1 or 2, and the very next day you can start increasing if they're tolerating. So don't have a specific time period unless it's a 22 or 23 weeker, in which case you would keep them on trophic feeds for a longer time. After the baby start tolerating about 60 ml per kilo and they are opening their bowels regularly, even if it's a 1000-gram baby, you could start going up to 30 ml per kilo. But if you choose to go with the 20 ml per kilo rate, it's fine as well. But go on the higher side of this range. Don't stick on 15 or 20. Go to 20 or 30 according to what suits. Human milk fortifier is usually started when the baby is on 80 to 100 ml per kilo per day. And usually we start with half strength for a day and then go to full strength. I'm not exactly sure about the HMF you get in India, so we will discuss that in the end. Wean the TPN off during the period when you are coming to nearly full feeds. The total fluid intake we aim is 160 to 180, and when we reach 130 and above, you may stop TPN because of the cost and the central line implication and just give clear fluid. Most of the time, we keep the central line till the baby reaches the full volume. So we use that to keep the clear fluid, and it's an additional day, and hopefully you can manage. But if there is any issue with the line, we remove it, and we can accept a lower total fluid intake for a day if the baby will tolerate it. So the frequency of feeds during trophic feeds, you may give 2 to 4 hourly. It's a small volume of feeds, so the nursing staff may prefer to give less frequently. But once you start progressing, we move to 2 hourly, and then we maintain 2 hourly till the baby is on full feeds and coping off the non-invasive ventilation. So the 2 hourly feed stays till the baby's weight is 1.5 kilo or so, and the baby is off the respiratory support. If you are on non-invasive ventilation, irrespective of the weight, we try to maintain 2 hourly feeds to reduce the risk of reflux. But this practice can vary according to your unit, and those who use 3 hourly feeds, they say it works, but my preference is to keep 2 hourly feeds. The reason is if you give 2 hourly, you are giving 1/3 less volume in the stomach at any period. So there is a possible reduction in the respiratory concerns like intermittent hypoxemic episodes from reflux. So you don't really gain much apart from the nursing workload when you go from 2 to 3 hourly, but you could gain by reducing these concerns from reflux, and over treating the baby from these episodes would reduce. So when the baby is stable, we go to 3 hourly and then suck feeding around the same time. Human milk fortifier is obviously a product that is added to breast milk, express breast milk, after the baby reaches 80 ml per kilo. It increases the calorie content and the protein content from the express breast milk. It matches that we get from premature formula. It also adds sodium, potassium, calcium, and phosphorus. Some of the fortifiers have iron, but it depends on what you are using. If you're not adding the fortifier due to availability or cost issues, you need to add additional calcium and phosphorus, and WHO has recommendations for adding these for the premature babies as well. So if you're adding HMF or the baby is on preterm or supplemented formula, you don't need separate calcium phosphorus. The human milk-based HMF has come up in the recent years. Obviously, there is a lot of market push for it, but it is very expensive and there is no clear evidence to show that it really makes a difference. So you have to judge according to your local situation. Maybe if a parent can afford and you have it available, you can use it. But as a general routine, it's going to be difficult. All the premature babies would need vitamin D, and we usually give a higher dose. So the fortifier might give you like 300 units, and we may add another 400 or 600 units. Some premature babies who are extreme preterm, we give 1,000 or even more when they are at highest risk of osteopenia. And osteopenia of prematurity is not a big issue after we have the recent TPN changes as well, and we start fortifying the human milk, and we don't see much of our osteopenia of prematurity. And of course, the premature baby needs iron supplement after 2 to 3 weeks of age. Whether you start at 2 or 3 weeks can be a unique policy, but you can say you will start iron once you're on full feeds and tolerate it well. Just a quick example of how you would approach. We have a 29-weeker, slightly growth restricted at 1.2 kilos. Baby has RDS and is on NAPPV. On day 1, the UVC was inserted and starter TPN with lipids was started. You can start dextrose till the TPN comes if you are getting the TPN from another center or you don't have a ready-made standard bag. You can also start oral colostrum care as soon as the milk is available. If the mother starts expressing within the first hour, obviously the output is going to be better. On day 2, you would go to 100 ml per kilo, start trophic feeds at 10 to 20 ml per kilo. And on day 3, increase 20 ml per kilo. And if feed is tolerated, you move to 20 ml per kilo, 2 hourly feeds plus TPN. And day 4 will be 40 ml feeds and remaining as TPN. The TFI has gone to 140. On day 5, to TFI 160, total fluid intake, feed 60, and the rest TPN. And day 6, you will be 90 ml per kilo feeds. Day 7 will be 120 feeds and so on. So once the baby starts tolerating 60 ml per kilo, as I indicated, we started going up on the higher level of the range, which is 30 ml increment. And by day 8, the baby is off the TPN. And by day 9, you can remove the central line, or even day 8 if you want. So if you are comfortable, baby is tolerating. So this is a kind of step-by-step approach. And that is the reason you don't want a significant lag in the beginning, because you would not break protocols. You may not increase faster just because you didn't get milk for the first 2-3 days. You still go step by step. So every day you delay is going to be a problem. The important question of residuals comes up when you're feeding the premature baby. So it's very controversial. It's not important whether we check for residuals or not. Most of the time, the nurses check the aspirate, but the importance of residual is you're emptying the stomach fully. So when you suck out more, there is a risk of gastric mucosal irritation. Use the syringe with the lower suction possible, and don't do the full residual check unnecessarily. If there is a concern, you can do that along with abdominal girth. But checking the tube position just needs to withdraw 0.5 ml or so, while to check residuals, you are actually emptying the stomach. So avoid checking the residuals if the baby is stable. And more important question is how we respond to residuals if you have. We shouldn't hold the feeds as we discussed in the earlier slide. You don't want to delay the progress, so you wouldn't hold the feeds unless there's a clear reason. And many of the units, unfortunately, the night shift, you're worried about what the consultant would say the next day, so you decide to hold feeds as a safer option. You can hold for 1 feed or 2, but don't hold for a full shift, because 8 to 12 hours is a very long time when it comes to cumulative line hours or days. And the team should be empowered to make decisions, give them a guideline. That's why the standardized guideline is important, how to handle residuals. And so you would use the smallest volume syringe for checking the residuals to avoid the excessive suction. Never use the suction catheter to empty the stomach. This should be drilled in right from the labor room period. If the gastric residual is less than 30% of the cumulative feed volume, you would assess the baby and replace the aspirate. You may hold that feed and or give the rest of the feed volume as fresh milk. We avoid discarding the residual volume because the gastric secretions, the stomach enzymes, everything is mixed with it and it is rich in electrolytes. So don't discard it, just replace it. And if you have a little more volume, you give the milk instead of that. The residual volume is a cumulative feed volume. If you are checking every 2-hour feeds and you are checking the residual over 6 hours, it's a 3 feeds of 2-hourly volume. If you're on 2 ml or 3 ml 2-hourly, it's 2 times 3, that is 6 ml is a total feed, and 2 ml will be 30%. So that's how you calculate the cumulative residual. If the residual is more than 30% but less than 50%, since the last aspirate, replace the aspirate but reduce the feed volume by 20% and continue to monitor. By monitoring, we mean feeling the abdomen, listening to the bowel sounds, the clinical stability of the baby, and the vital signs. If the residual is more than 50%, or if the baby is vomiting or shows other signs of clinical instability, we consider holding the feeds for 2 feeds and restart with 20 to 30% less. But if concerns persist, obviously you don't want to miss NEC, so you would screen the baby for sepsis and do an abdominal X-ray. And if you are on non-invasive ventilation, consider reducing the support if baby will tolerate, because sometimes When the baby is on NAPPV, they get a high gas flow, and that may affect their feed tolerance. So if you are on high flow or CPAP, it becomes a routine to leave the feeding tube open 15 minutes or so after the feed, and you can leave it suspended a bit high so the milk doesn't flow back. We discussed earlier about use of glycerin suppository if the baby isn't passing stool spontaneously. So we may have a PRN order of once in 48 hours if the baby doesn't pass stools. More rapid evacuation of meconium in the first week may improve feed tolerance in extremely low birth weight, though there are some studies, there's no clear-cut evidence, but you may use it if the baby doesn't open regularly. So prophylactically, no, but if baby has reduced emptying, you can. There is no role for PPI or ranitidine. And ranitidine, of course, isn't available in most of the countries. And omeprazole should never be used to treat feed intolerance because you need the gastric acidity to protect these babies against the risk of NEC. Erythromycin use has insufficient evidence, but if you're considering ureaplasma infection and you want to give a course, you can do it to meet both purposes. Most units nowadays use probiotics, but you should be sure about which product you are using. The quality control of these is important as well. And it's important, and we do use probiotics in babies under 28 weeks after they reach 50 ml per kilo of feeds. So this is a summary of the feeding of premature babies. I have not discussed term babies, but there are many videos on my channel about breastfeeding and supporting breastfeeding. I hope this is useful. We can have some questions if any of you have questions.
Thank you, sir.
Thank you.
Yeah, it was an excellent talk, and it was a very briefly you have described all the really the as early as possible we should start up the feedings, and we should not keep a baby on a or not we should not delay the feedings. That's a key message what we got for the preterm infants, and the part of the TPN and the nutritional part should be taken care with the any emergencies. That was a key. Yes, sir.
Thank you.
Sir, one question. I'm Dr. Nitin here from Baroda.
Hi, Dr. Nitin.
Sir, you talked about starting lipids for a 32-weeker baby, less than 32-weeker baby, from day one.
Yes.
Normally, I am not aware about others, but at least in our ICU, we follow this protocol for less than 28-weeker baby and less than 1 kg, rather than 1500 and 32-weeker. So, what is your opinion being practical and cost effectiveness? So, is it okay if we apply this rule for less than 28-weeker and less than 1 kg, or what you're talking is utmost? Because as of now, we don't follow this rule of 1500 grams and 32-weeker.
No, I mean, I did explain that TPN decisions are made after a lot of local discussions on your facility support. And if you are starting TPN in a baby less than 32 weeks, if they are relatively stable, you may not start TPN. Less than 1.5 kilo, if they are very close to 1.5 kilo and the baby is stable, we don't start TPN. But 1.25 kilo and below most of the time, and less than 30 weeks, definitely most of us would start central line. If you are starting TPN, you would go for full TPN. I mean, you don't need to hold back. The lipids, of course, on day one, we may just give 1 gram, while amino acid, we go directly to 3 grams. And lipid progression on day 2 itself, we go to 3 grams. So previously, we used to go 1 gram at a time, which we don't do anymore. And below 1 kilo, below 28 weeks, there's no question at all. Below 1.25 and below 30 weeks, majority would get it. Very few, if you don't afford, you wouldn't start it. 1.25 to 1.5 and 30 to 32 is an individual call. If you are having a sick baby and you have a central line, you would start TPN on day 1. But if you want to wait 2 or 3 days, as I mentioned, you can. But each day, your catabolism and the risk is going to increase. So you may not delay too much.
Thank you so much.
There is a question which probiotic we use. We have only one reliable product in UAE. It's called Biogaya, which is a manufacturer name, and it's Lactobacillus reuteri. We give 5 drops and we give it mixed in the milk and feed the baby. The product is kept in the fridge. Once open, we keep it for 1 month.
Sir, fluid restriction sometimes in babies with PDA, CLD, we do fluid restriction. So does enteral feeding during enteral feeding we should do fluid restriction or feed restriction in those baby, or it doesn't lead to fluid overload?
See, the conservative management of PDA, I mean, using diuretics or fluid restriction is not really evidence-based. and you wouldn't give excess fluid. So you have to differentiate between giving excess fluid and restricting fluid. The only situation we really restrict fluid is where you have birth asphyxia, for example, where you are starting with the lower, or if you have renal failure, you have to definitely restrict to insensible water loss. So in a premature baby with PDA, you just give enough fluid. You make sure you're not overdoing the fluid balance. So I see many premature babies who are gaining weight like 50 or 60 gram per kilo per day, and you still don't restrict them. That's wrong. If your baby is gaining 15 to 20 gram per kilo per day, that's more than enough weight gain. And if I even bring down to 120 ml per kilo per day in these babies, if they have BPD and they're gaining weight, well, overall calorie intake is reasonable, but you have to balance with all these aspects as well. So don't go overboard with the fluid restriction. Just give enough fluid to manage the weight gain of the baby. Don't restrict more than that.
Sir, one more question is there. Sir, you said in your protocols uh, that newer changes in the TPN, what you do has decreased the incidence of osteopenia of prematurity. Sir, what are those changes?
I didn't discuss it in detail because the idea today was enteral nutrition, but
Yes, sir.
calcium phosphorus ratio is the main one, and we start with the full dose of phosphate from day one. And vitamin D supplements, we go for a higher dose. But there is a separate video on that. I'll share it with you.
Okay, sir. So phosphate you add in the TPN itself because calcium phosphate then precipitates can
We have the
happen.
organic form of phosphate. The glycerophosphate is less risk of precipitating. So
Okay,
we're
sir.
able to maintain a higher dose of calcium and phosphorus in optimum ratio. So the balance is better maintained. We don't have precipitation with the organic form of phosphate, the glycerophosphate it's called. You can try to see if you can source glycerophosphate,
In India, only one phosphate is available.
the
So that's
inorganic one.
an issue.
Sir, do you have a most of extreme preterm babies, basically less than 26 week? People used to start the continuous feed from day one, irrespective of respiratory support or other non-invasive support. Do you have any experience for that one? Because we
No,
have
no.
we are happy with the continuous feed in particularly less than 25 week. So nutrition and everything, I don't know, it is compromised or not, because we have a donor's milk bank available in our private setup, so we can manage to give with the continuous feed.
I mean, there are, in certain babies for a very short time. I mean, if they are just extubated and you don't want to risk the reflex, and you may consider continuous feeds for a brief time or hourly feeds. But when the baby is in the initial stages, when the feed volume is low, it doesn't make a big difference, and it's much better physiologically to give bolus feeds for the gut hormone stimulation and also the nutrition. I mean, there are some issues with the continuous feeds with the fat adhering to the syringe and so on. So the nutrient value may change. The milk is exposed for a longer time outside, especially if you're adding fortifier, the stability and the balance, some components may reach in different ratios. So I don't practice and I've not seen other colleagues practicing it either. So continuous feeds can be used for a very brief time to tide over a baby. Suppose you don't want to re-incubate a baby who is just extubated and is on mainly feeds. You may give continuous feeds for a day or so to try, but even in those situations, we didn't find much benefit. So hourly feeds also is like that. I mean, you give a very small volume when you give it every hour. So, but it's very nursing intensive. So you don't want to do it unnecessarily. You only do it for a very short time if needed to tide over crisis.
If baby is on the non-invasive support and if you are giving a continuous feed, do you take any breaks in between that one? Because the flow is going to the tummy, and ultimately we need to, sometimes
You
there
do
would be the
check, I mean, you do disconnect every 4 hours to change the milk. So you would check the residual or the tube position at
okay.
that time. But even if a non-invasive mode, we keep on 2 hourly feeds and it works well. So most of these practices are more habit driven. So once you convince the team that continuous feed isn't needed, you can try giving the 2 hourly feeds. And if for a short time you feel babies very high risk of reflex related changes, you can give hourly feeds for a day or so. When I was in UK in the beginning, we used to use hourly feeds very frequently. But in the past 10, 15 years, everyone is moving away from hourly feeds. 3 hourly feeds is an excess volume. So there are many units in US who go straight for 3 hourly feeds and they say they work well. But the comparison, for example, most of our discharges happen at 35 weeks when they reach even a 28 weeker goes home at 20. But those units they discharge at 35 to 37 weeks. So the 2 week difference in stays there, it's not worth it. So because the intermittent hypoxemic episodes delay your progression with subfeeds. So it's just the balance. So if your team is feeling that continuous feed is better, try to give a period without it and see. I mean, it's similar in many situations where we use a medicine unnecessarily and then we stop it and realize that we didn't need it in the first place.
Thank you.
Thank you. You're muted, Dr. Kunal.
Yeah, we have Dr. Uma Madam and Dr. Sheila Madam also with us, who are our advisors for Gujarat State NNF. Madam, would you like to say anything?
Hello, good afternoon.
Good evening, Dr. Uma Naik here. I'm a professor of pediatrics at a private medical college now after retiring from government. And I've been there for about 5 years. And just in the last few days, Sheila will speak for herself. We've got Sheila into our team also. And I expect our newborn services to skyrocket after that. She's going to be here. And today only we were discussing a case, a similar preterm and feeding, etc., etc. So we really told our residents also to attend. It was very nice to attend the session. Thank you so much.
Thank
Sheila.
you, Dr. Uma. Pleasure. Thank you.
Hello. Am I audible?
Yes, ma'am.
Yeah.
Yes, ma'am.
Hello. It was very nice lecture, Dr. Sridhar. You also said very less about it. The mother's milk for fortifiers, which are being very aggressively marketed. As a part of BPNI, all of us have been little against it. Do you have any personal experience of using them?
I mean, here the cost factor is inhibitory because we have something called the DRG system from the insurance. So the bill is fixed according to the diagnosis. So whatever you do, you get the same amount. And if we are using the human milk-based fortifiers, about 1/3 of the bill will go to them. So the hospital is left with nothing. So it's that's why the evidence-based doesn't suggest strongly. And I personally don't think you need that. The recent US case also, I don't think the judgment was in the right mode because it makes it very negative for the. Now they are targeting the company, but they can easily come back and say the neonatologist started the formula. So where we don't have an option and the EBM takes 2-3 days, whether we give TPN and risk delaying the central line exposure. So everything becomes multifactorial and it's not easy to make decisions. And I don't know if you have breast milk banks regularly in Gujarat, but in UAE, we don't have because of the religious connotation. I mean, if you have someone else's milk given, they become siblings. So to track
the government sector.
Most of our places have.
Yeah, but as I said, I think the stock would be an issue, isn't it?
We have it in my private sector. Yeah.
You would prioritize it to the highest risk.
Prioritize the babies. So we do give it for the smaller babies. And, we don't give it for the bigger ones. Sometimes there are more of bigger ones who nearly empty our milk bank. But so we have to prioritize it sometimes, yeah.
Thank you for your comment, Dr. Sheila. And it's great that you have the donor milk banks. Do they have access for the private sector as well for the donor milk banks?
Private sector cannot get it from it's because whatever the bank for the institution we are trying to collect, it just covers the workload of that particular unit. So we need to have more banks, more donation, then probably we'll be able to cover the private sectors more. Other one issue was that they are claiming that you can fortify by 40 ml per kg with the human milk fortification. Any comments on that?
I mean, growth has to be balanced with the risk as well. So when you increase the osmolarity of the products very much, you may increase the risk of NEC. So I know, I mean, growth is critical for the brain development and everything. But if a baby gets sepsis and you're set back multiple days from being on TPN related complications, exposure to antibiotic and everything else, it balances out. If you manage a little slower growth profile without infection, you probably end up in a better scenario.
I mean, we have kept it as almost 100 ml, means 80 to 100, because we have in lot of our, even in due to overcrowding and all, sepsis rates are high. So not really. But one thing, without probiotics, till now I was with the government sector with an overcrowding, but our NECs are very low rate of NEC.
Breast
Maybe
milk.
one thing is strictly human milk being fed to all of them, very little of formula. And we have a lot of IUGRs, so those reversal of flow and those babies are many. But the extreme prem of 25 and 26 week, we are not much in number. So that that risk factor is less, but IUGR factor is quite significant. But our rates are very low, very.
In our place, we got the breast milk bank only a year ago, and we could see that earlier also we were trying not to have NEC, but there were a few NECs which we have definitely completely come down after the milk bank has come in. So that difference we can
hopefully the infection can come down as well, which will make it much
infection
easier.
is still there, less than the overcrowded place. My place is not overcrowded, but for the fewer, comparatively fewer babies that we have than the government sector, still the infection rate is not as low. I would definitely like it to be much lower. Yeah.
I think minimizing the intervention seems to be the key to reducing the infection rate.
No, actually, we get outborn babies, and being a medical college in the rural area, so outborn babies, we do accept all of them, and some of them are in a very bad shape, and we try to isolate them from others and all.
It's
but
never easy. Gram-negative infections are so rampant in India.
We can't do it much.
Yeah. Thank you. It's amazing to hear from all of you. And you have the human milk fortifier, the commercial form of the cow's milk based fortifier quite readily, or it's expensive?
It's expensive. Only one company, the Neolecta, has been trying to promote, but
no, not the human milk one.
Not human. Cow.
Ours is the bovine.
The bovine one, is it readily available?
It's readily available. Only one company is selling it.
And are you discharging the premature babies on calcium and phosphorus routinely?
Yes,
we don't do that here.
No, we are discharging them, and we supplement it till definitely 40 weeks of gestational age. We have been doing their screening for all preterms also with their biochemical investigation.
And you're also moving away from checking residuals, I think, no?
Oh, yes. We just go by abdominal girth, or is there symptomatic then only. No residuals to be checked.
Amazing to have experienced people contributing. Thank you so much.
Monish, sir? Can we conclude?
Yeah, we can conclude now. Yeah.
Thank you so much, Sridhar, sir. Yes, we do have Uma ma'am and Sheila ma'am are my mentors. They have given, I have to continue that legacy. So we do practice early enteral feed. We do practice this colostrum swabbling. We do practice early screening for the osteopenia of prematurity. And really very happy to have you on this platform. Thank you so much, sir. We have a wonderful CLMC, that is Comprehensive Lactation Management Clinic, Human Milk Bank. But we are just now catering to our own babies only, not to the private sector. One or two exceptional cases may be there. So this is our senior, almost what you are practicing, we are also practicing at our state. So thank you so much for being with us today in Neonatal Paatshala.
It was my pleasure. Thank you so much, everyone, for actively participating, and I really appreciate your invitation.